Happy Halloween, happy Friday. I will be the first to admit that I do nothing on Halloween, because I'm an incredibly lame human being. No. Not doing anything today, but I'm hanging out with family tomorrow. For those of you who are celebrating today, I hope you have a fantastic time. For those of you who are likely watching this video on YouTube, you're probably choosing to do this over celebrating Halloween. High five to you. I would do the same. Today is an all internal affair. And first, we should probably thank the people who are anchoring this session. And scribing is Jillian, and doing teaching points is Zachariah. So I'll hand the mic to each of you for a hello, and then we'll introduce everybody else.
Hello, I'm Jillian. I'm doing scribing today. Excited to be with all of you on this spooky day.
Hi everyone, I'm Zachariah G. Also really excited. I think this is Jeffrey's first time discussing on a Friday, if I'm not mistaken. So hyped to learn.
Indeed, indeed. We'll save the suspense for a moment and thank our case presenter. So Aaron started from a prolific case presenter to one of our most recent Academy members. I think Aaron, this is the first time that you're presenting publicly as an Academy member, so very excited for that. Hand the mic to you for any updates you have for folks, and then yes, we'll chat about Jeffrey.
Hey everyone, I'm Aaron. I'm a medical graduate from the Philippines. I'm based in New Jersey, and yeah, as Robbie said, I've recently joined the academy, and it's been a whole lot of learning, literally like every day. It's been so fun. Yeah.
Yeah, it's been a treat to have you. It's amazing to go from a stranger to like hanging out for an hour to like hanging out multiple times a day and learning together. It's just so cool. And yeah, very excited for your case today. And Aaron, Jeffrey followed a similar path. He presented, and then he couldn't stop presenting, and then we trapped him and brought him into the academy, and it's been surreal since then. I think, as I've said before, I think we've discussed together with Ravi once, and it's very rare to have the clinical reasoning bug and the impetus to continue to refine your diagnostic skills once you're a seasoned attending like Jeffrey. I think many folks have developed interests in different parts of medicine, and so to have somebody to retain that initial joy in medicine, especially when they're subspecialists, is unreal. And know that Jeffrey brings the heat and has taught us so much. I don't know how many internal sessions he's done. It's gonna be triple digits sooner rather than later. Definitely in the far into multiple several dozens of rapid fire cases. So very excited to share with you the stage today, Jeffrey. Maybe I can hand the mic to you to say hello, and then we can rock and roll.
Yeah, thank you so much for that really warm and touching welcome. I'm equally blessed to be part of this community. I've learned so much, and I continue to enjoy learning. Even all these topics, a lot of them they're not like rheumatology. I think the last like one of the ones I just recently went to was about AFib. It was amazing. You just being able to learn all the time, and so thank you so much for letting me be part of this community, and super excited to get to share the stage with you. So yeah, let's do it.
All of you who are not part of the academy, you are two UTI cases away from hanging out with Jeffrey. Present one simple case of cystitis, one simple case of diuretic-induced hypokalemia, and a signed coat from Jeffrey. I'm kidding. But teaching delivered from Jeffrey straight to your house awaits you. But let's kickstart the session today. Ready whenever you are, Aaron.
All right. So for the first aliquot, we have a 77-year-old male coming in with dysphagia, and I'll let you guys just.
Jeffrey, bamboozle us, please.
Oh, I'm starting with dysphagia. Okay. All right. Well, I'm curious to hear what your approach is to this. I think from my side, from what I remember, we try to separate dysphagia with is it coming more from the esophagus or is it coming more from like above, like in the oral pharyngeal area? And then there are some questions that we can ask on history to try to help with clarifying like which is more likely. Like sometimes we can ask them to point to where it is, and sometimes we can ask if they're having aspiration or like regurgitation, nasal regurgitation, which we point more to like oral pharyngeal dysphagia. And so I think because he's 77 years old and he's presenting with dysphagia, I think this is a very concerning symptom. So we talk a lot about, like, in clinical problem solvers, about how to differentiate between signal and noise. And I think right now I'm not seeing that how this dysphagia, as a presenting symptom, is going to be noise. So I'm going to focus a lot on trying to figure out what this is due to. There's a lot of structures that need to be that need to work in order for you to be able to swallow appropriately. So we talked about the anatomic structures. So like the oropharynx and the esophagus, anatomically, they're tubes, so they need to be intact. So there needs to be no damage there, no inflammation there. There needs to be no anatomical obstruction, such as by a mass or a tumor. And then in addition, the function of swallowing itself is a entire neuromuscular process. So all of that, from the brain to the nerves to the muscles, also need to be intact for that to work. And I'll hand the mic back to you, Robbie.
I'm right there with you. I have nothing to add to that reflection. I think it's profound, and I have a room flavored question for you just to add at the end of this. But I'll just share that one feature of dysphagia is generalizable, which is that the patient's not going to be having dysphagia when he sees us, and that's because most people who come to see Jeffrey and I are not in the midst of eating or drinking at the moment we see them. And so really, what he is saying is whenever I try to put something in my mouth, I have trouble. And so you already know that this is a triggered syndrome, not a continuous one. And whenever the trigger do something and then something bad happens, it's very, very hard to make the diagnosis by observation of the patient when the trigger is not happening. And if you ask me to close my eyes and imagine every single patient with dysphagia I've seen, and if I were just to take a picture of them and show them to you, you would have no idea that they're having dysphagia. Now, you might see the consequences of prolonged dysphagia, or you might see clues as to the cause. So if you saw somebody with hemiatrophy on one side, you might think they've had a stroke and they have dysphagia, or you might assume that because of their weight loss, they've had dysphagia for a long time, but you'll never actually be able to see that they have dysphagia. And so I encourage all of you, whenever you have a triggered syndrome, to try to bring it out. Now, I should asterisk that and say that there are some triggered syndromes that you probably don't want to bring out. So if somebody says, "Hey, doc, I have crushing substernal chest pain anytime I walk," you may reconsider walking them, because walking them may induce a horrific heart attack. But in most instances, bringing out the disease just enough for you to be able to see it and then letting it go back again is a wise idea. And so if I synthesize those two things and tell you that in a patient with somebody with dysphagia, I want to bring it out and see what happens. What happens when they eat? But I would not be asking them to chew down a hot dog, because what could happen is they could get acute obstruction superimposed on their dysphagia and have horrific consequences. So what do? I give them a sip of water to test how they swallow water, and I give them a ice chips to test solids. Now, why ice chips to test solids is at body temperature, they melt very quickly. So you will not have an obstruction from ice chips. So this is an intermittent syndrome, and the tip to an intermittent syndrome is always, if you can safely induce it, then do so. That'll tell you a lot about what's going on. But Jeffrey, I don't want to lose the opportunity to sort of use your expertise in particular. And I'm curious, if this turns out to be a rheumatological diagnosis, what would make the most sense?
Wow, that's what a challenging situation. I will say, just without having too much thought, like instinctively, because when I see it, most often what happens is it's because of a neuromuscular dysfunction. I probably would say that the most common one we see is myositis, because the muscles get affected in advanced myositis. But if this patient were younger, then scleroderma is also like a very common cause of dysphagia. So those are the two, like, just in terms of prevalence, of two first thoughts.
Amazing, super, super helpful. Alrighty, Aaron, what you got next?
All right, that was a great discussion. And you're right, it is very important to classify the dysphagia. So for this patient, further history, 5 days ago, that was when he started noticing this onset of difficulty swallowing solid foods, and this was not associated with pain with swallowing. There was also no other associated symptoms with this. Until 2 days prior, he now noted additional difficulty with swallowing liquids as well. And now he noted some difficulty opening his mouth. So he says it was just very difficult to eat. This progressive dysphagia was also associated with intermittent episodes of chest tightness, not necessarily during eating, and as well as intermittent abdominal cramping. 1 day prior to presentation, the patient noted intermittent stiffening of the bilateral upper and lower extremities. This was not associated with any loss of consciousness, bowel or bladder incontinence, headache, dizziness, numbness, weakness, or any altered mental states. The patient sought consult at an outside hospital and was given diazepam for his spasms, but ultimately was transferred to our institution for further management. And I'll stop here.
Jeffrey, I'd love to hear your thoughts. I'll just jump in to say, Aaron, there's a little glitch there. I think we caught everything, but I'll let you know if it happens again, just because it might be helpful to temporarily turn your video off. But I think Jillian, I think you caught everything. Yeah, Jeffrey, what an interesting twist. I'm curious, what are you thinking now?
Okay, I'll just tell you what's like the surprising thing, like just from listening to it, is like he mentioned like mouth, like something about the mouth stiffening or like the mouth not being able to open. So when I imagine people with dysphagia, I don't often hear that like they have problems with their mouth actually. So that like jumped out to me. And then the other thing is, mentioning like other symptoms like intermittent chest tightness with abdominal pain unrelated to the, dysphagia, and intermittent stiffening of upper and lower extremities. Like none of these like are things that I would typically expect to hear in someone who's presenting with like dysphagia. So it's really interesting. Like I will say, like the off the like top of my head, the first thing I thought of was giant cell arteritis. And we'll see later on if that has anything to do with that. But there's multiple ways for you to have a systemic disease and then have dysphagia as part of it, which it seems like that's where we're heading to. If we say that these are all signals, like then we would have to say, because you have extremities involved, you have like swallowing somehow involved, in order to have multiple systems involved, I think that this would be like a multi-system disease. I think if I look at the commonalities between these areas, like what are the things that are in common, right? So like what would the throat or like this region centrally and also the extremities have that are in common? So we talked in the beginning about like neuromuscular function. So they certainly all have nerves, neuromuscular junction, muscles. So like any systemic process that's affecting all of these could be at play. That's probably the primary thing I'm thinking of, instead of a systemic disease that is affecting different processes through different ways, right? Like I mentioned earlier, scleroderma, that disease is sometimes really difficult to diagnose because the way it causes the different symptoms are unrelated to each other, right? You have like a vascular problem here, then you have like a scarring problem somewhere else, right? So right now, I think just because we're just like starting the solving or investigating what's going on, I'm going to be more attuned to like, is this a problem that's in like one location, like in the muscles, in the nerves? That's where I'm looking at so far. I don't see a way of this to be something, I don't see a way for this to be something like anatomic, like just there in the esophagus, unless, for example, we realize later that like that thing that is coming in, that's like in the esophagus, let's say, for example, an esophageal cancer, is causing something completely different, like a paraneoplastic syndrome. But before I get to something like that, where you have a complex like combination of things, I'm going to be focusing on like one process maybe that can explain it. I'm curious, how do you approach this?
Yeah, I'm right there with you. I think that, it's very, very clear that unlike most patients with dysphagia, the center of gravity seems to be diffuse, and the patient has almost head-to-toe symptoms. And the other thing that's unusual is the tempo of disease. So if we just then take a moment to sort of emphasize why your thoughts are so precise, is because the vast majority of patients with dysphagia have about 2 or 3 unifying diagnoses. The first is is central nervous system diseases. So strokes, dementia syndromes, Parkinsonism causing oropharyngeal dysphagia. And those are almost always either subacute to chronic or unilateral. And so this is neither subacute to chronic, nor is it unilateral. And so the vast majority of oropharyngeal causes of dysphagia are made much less likely in that circumstance. Esophageal dysphagia, no matter the cause, is usually the result of an obstructing process, be it a stricture or a mass. And almost all of those are subacute in nature. And so for me, Jeffrey, I think this case is unusual because of the time course and the bilaterality. I think the only progress that I've made is that I think the localization of this dysphagia is almost certainly oropharyngeal based on the fact that the patient is localizing the difficulty to his mouth. And so whatever it is, it seems to be unusual because it is oropharyngeal without a gentle time course and without asymmetry. And I think the interesting thing is, yeah, sorry, I just got distracted by admitting folks. The interesting thing I think to take advantage of is to study the pattern of evolution, which is that it's progressed pretty quickly from solids to liquids. And that progression from solids to liquids imply, well, I should just try to make that point maybe a little bit more simply, which is that if you have a neurological cause of dysphagia, it doesn't matter what you're putting in your mouth, you can't move it, solids or liquids. And so they're affected fairly equally. The progression from solids to liquids implies a progressive structural cause. And I'm so struck by how quickly the structural cause is progressing. But there's a paradox, I think, here, Jeffrey. And I think that paradox is the progression from solids to liquids suggests a structural cause in the oropharynx. However, the accompanying features of stiffness and tightness suggest a neurological cause. So how do we acknowledge the tension and try to make progress of this seeming paradox? I think the fact is this is unusual because it's bilateral and rapidly progressive. This is also unusual because there are features of a structural issue, which is the patient cannot open his mouth very well and has a progression from solids to liquids. But at the same time, he has neurological features to his disease with stiffness and rigidity. And I find that paradox to be very, very interesting. And before I really do anything, I'd probably want to lay hands on him and examine him and see what is the signature that I can see, because his history is very, very perplexing. And so I would just leave it at that. Base rate is for dysphagia subacute to chronic with unilateral features. Here, he is bilateral and acute, and so it's very rare. Most oropharyngeal dysphagia you can divide into confidently neurologic, where the patient has simultaneous liquids and solids, or confidently structural, where a patient has a progression from solids to liquids. Here, the patient has features of both, and I think the overlap is very, very interesting. Any reflections on that or anything you wanted to add before we hear from you?
Rami, I have one question. I think so. We mentioned a lot of things. I guess both of us skipped over chest tightness and abdominal pain, and I'm wondering, like, where do you fit that? Do you think those are maybe non-specific features, or is there any other way that you would connect that here?
I am, but I think it would probably be a leap in real time. But I'll just share with you one interesting element of muscle diseases. And it was interesting, Jeffrey, because remember when we chatted about like what rheumatological conditions do you think it makes sense? And you were like, oh, a neuromuscular weakness. And dermatomyositis in older people is a great example, right? But muscle diseases don't cause problems. Muscle diseases don't just cause problems by being weak. Muscle diseases can cause horrific problems by getting really tight and stiff. And I think one very simple explanation for why somebody has a neurological issue that is causing a structural phenotype is diffuse muscle stiffness, whereby the muscles become so stiff and so rigid, they cannot move and therefore have a neurological phenotype. but they also become so stiff and so rigid that they almost look like there is a mass in the way. And so for me, my mind is open to the possibility that our problem representation will be an abrupt, widespread muscle rigidity disease. And so I'm eagerly awaiting to see what exposures this patient has, because the vast majority of abrupt onset diffuse muscle rigidity syndromes are meds that this patient is taking or not taking, or even as esoteric as certain spider bites that you can get, which is not a good thing to mention in aliquot number 1, but also some really bad infections that you can get. So yeah, the way this could unite is a muscle rigidity syndrome, Jeffrey. But this is why I didn't say it initially until you prompted me, which is that is such a rare problem to have. And so before you start to have tunnel vision on like a New England Journal CPS showing up in your emergency room, like you should check yourself and get real. It's probably a twist, a more an interesting twist on a very common problem. So that would be the way I would unify it, but I wouldn't do so quite yet. I think I'd try to see if there's a more simple explanation for what we're seeing. What about you?
And the only other thing I thought about is, what if I organize this whole thing incorrectly? This patient is having like unstable angina or myocardial infarction. The
Totally.
important thing is the chest tightness. The intermittent stiffening is like unrelated, maybe claudication. And then the dysphagia is the radiation of the pain from their heart up there. I don't know. I was just trying to organize it a different way. Like, are we doing this the correct way or not? But I'm very curious to see what happens next.
All right, Aaron, Mike to you, my friend.
All right. Thank you for that discussion. Very interesting thoughts. So for the review systems, it was otherwise negative. For the patient's past medical history, it was unremarkable. Besides, he was previously treated for pulmonary tuberculosis 20 years back, but otherwise he has no past medical history. His family history is also unremarkable. For social history, he works as a furniture upholsterer. He's a 5-pack-a-year smoker, otherwise no alcohol or illicit drug use, and he does have a pet dog at home. I guess I'll just stop here and see if you have if this adds anything to your thoughts.
I can just reflect real quick. I think, Aaron, as we were chatting about earlier, I think it's so hard to make progress of the background information when the foreground itself is unclear. So you heard Jeffrey and I authentically saying that it would be a mistake to pretend like you know what problem you're solving. We both are entertaining things as far apart from each other as baclofen withdrawal to acute coronary syndrome. So what happens in my mind here is I say, thank you for this information. I'm going to revisit it later once I have a more clear view of the foreground. Because I could stand here and put on a suit and bow tie and be like, tuberculosis can cause a rigidity syndrome by invading the meninges, and this is possible in this patient. I could also say a dog may be rabid and bit the patient, and this patient could have rabies. But I think no person taking care of a patient in real time really thinks those thoughts. And so it would be nothing short of performative to say that stuff. But these things in the history all could be very powerful clues to what's going on. But when you have no real clue about what's going on, you probably are best served by putting them in pencil somewhere and then revisiting and saying, hey, what am I going to take and put in pen for this specific moment in this patient's life? Maybe Jeffrey, you got a little bit more juice than I did. Thoughts on that?
100% agree with what you just said. I would do the exact same thing. Yeah.
Awesome. All right, Aaron. Will this medical history be true, and unrelated, or is there a hidden gem right there? We'll see. Mike to you.
All right. For the physical exam for the vitals, we'll start with the blood pressure, which was 180/100, a heart rate of 108, respiratory rate of 26, a fever to 39.1 Celsius, and SpO2 of 96% on RA. So this patient, when we saw him, he was awake, but he preferred his eyes closed. He followed commands, but was kind of irritable. We tried to examine his pupils, but the patient was very irritable, so didn't cooperate with exam much. For the neck was supple. There was no cervical lymphadenopathies or masses. For the oral exam, the patient had dry chapped lips. We had a half finger breadth mouth opening, and inside there was very poor dentition with oral sores. And when we put in the tongue depressor, there was a reflex spasm, or just spasming in general. Cardiac exam, tachycardic regular rhythm, no murmurs, symmetric chest, clear lungs. The abdomen was flat but a bit tense to palpation, but it was non-tender, no guarding. And then when we got to this patient's lower extremities, I'm going to share an image. When we got to his leg, there was a something there, so we moved the pants up, and this is what we saw. And I'll stop here.
Robbie, are you saying something?
I'm so sorry. I was muted. I was telling you that I think you're muted. How ironic is that?
Oh my gosh. I was trying to figure out whether you were talking or not.
Oh no, I'm so sorry. I think yeah, I had forgot to hit unmute. Yeah, well, what did you think?
Gosh. I was well definitely I wasn't expecting that picture. And I guess I'm still in shock as to like what is that? I don't think I could say I've seen anything like that before, but wow. I guess, what we're dealing with is like an outgrowth and mass, like a fungating mass that's like an outgrowth on the leg there. Um, so I mean, obviously, trying to figure out the mass has now become the primary problem that I'm trying to solve. Um, I think just because of how astounding the mass is. At the back of my mind, I also know like there's also a possibility that this mass has absolutely nothing to do with everything else that's going on, but it's hard to ignore. So I think, what this mass could be, what I'd be most worried about is some type of like cancer or tumor. And then I'm not even sure, but like, could an infection, something like a fungal infection or something like that, cause a mass that looks like that? But the first thought I would have initially would be like, is this something that's cancerous that's like outgrowing, maybe something like a really bad skin cancer or a really bad sarcoma? I guess the question now that I'm like seeing the mass, the question is like, why did we not know about this mass to begin with? I guess, um, I'm sure that the patient knows that the mass is there. So I'm wondering like what the time course of the mass is. I'm wondering like if this mass has probably been there for a really long time, like so long that the patient himself doesn't think that it's related to what's going on now. But I think it would be helpful to know from the patient like what the time course is for this mass. Um, as far as like the other things that we're dealing with, like his on the exam, the fact that he has difficulties with opening his mouth and spasms there, again points towards a neuromuscular problem, probably being the primary cause for his dysphagia and maybe as well as the other symptoms. So I'm already like shifting the approach as like, how do I combine a neuromuscular syndrome with also this newly found mass? Are they related? Like, is this like a paraneoplastic thing, or is this a secondary infection of that mass, such as like tetanus or something like that? That is where I am focusing my thoughts right now. I'm very curious to how you process this.
Yeah, I think my thoughts are very similar to yours, Jeffrey. I think this would make my heart sink and it would make me discard everything I've heard on history. And I say that because once you realize that there's such a big vacuum in the history you've received, literally a 5 to 7 centimeter vacuum in the history you receive, you realize that the patient's relationship with the healthcare system is not one in which the information you're going to receive from him is of the highest quality. And that's not a judgment on him. In order to understand why that's happening, you really have to rewind the clock back to the patient and his life many, many years ago, and how his life evolved, and how especially his life evolved with the people around him and the healthcare system. And I imagine that the answer is it's very complicated. The counter argument to that could be that he's so debilitated by this acute process that he would have told us that this was there, but maybe this has taken over his consciousness enough that he was too ill to share that. And I would be entertaining both those possibilities, but both those possibilities are game changers and very ominous. And so they make the ground that we're standing on very wobbly, because you're like, well, where do I start? And I think you have to start with what you can see, and we see fever, tachycardia, hypertension. And I think the combination of fever, tachycardia, and hypertension creates a very, very narrow and alarming diagnostic space, because most acute fevers are infectious. But whenever you see fever in the context of tachycardia and hypertension, you have to think about the possibility of hyperthermia. Now, hyperthermia is very different than fever, because a fever is a very deliberate choice by the body to increase body temperature to fight an infection. But hyperthermia is involuntary and out of your body's control. And the reason your temperature is so high is because your muscles are so stiff that they're generating an unrelenting amount of heat that you cannot dissipate. And so imagine that you're running constantly forever and you can't stop. You'll become hyperthermic. You cannot dissipate the heat that your body is generating. And that's a possibility in this patient. And the way we'll know for sure is to see if there's been muscle activity by measuring a CPK, but also to see if we can make the fever go away with Tylenol. Because Tylenol can suppress the cytokines required to generate a fever voluntarily, but will do nothing for temperature coming from a highly elevated muscle tone. And we've already talked about why the muscle tone is in scrutiny here based on the HPI, and now we have more reason to be scrutinous about it, because the most important muscle for this patient's life, his mouth muscles, are so tight that you can't even access his airway. And there are two medical emergencies here: the possibility of hyperthermia and the possibility of airway collapse from malocclusion. And so the chances of needing to secure this airway are high, and the chances of being able to do so easily are low. And that creates a very, very emergent situation for this patient. Whatever is going on in his body is occurring in a twofold manner. There's a focal problem in his right lower extremity, but there's a widespread serious problem taking over his body. And how you connect the dots, I think, is to be open to the possibility that there is a, quote, paraneoplastic phenomenon happening from this. But I don't use the word paraneoplastic in the strictest sense. I mean it that this thing is secreting something or is releasing something into his body without regard to what it is. So if this is a place where he's had some trauma and he has tetanus emanating into his body from that lesion, or whether that's a cancer causing a paraneoplastic phenomenon in the true sense, I think both of those are possible. But the mass is not going to kill him in the next hour or two. The systemic widespread rigidity is going to do so. So I think treating him is going to be key. And I think this patient will probably need a lot of treatment. And so for me, I'm really asking, what is the diffuse molecule that's causing him to feel this poorly? And I was hoping, Jeffrey, that we would find a medication or a toxin that he's ingesting or not ingesting, like benzodiazepines or alcohol or opiates or baclofen or many others. But when that's not the case, I think you have to worry about an infection doing so, an infection causing a diffuse rigidity syndrome. And I think, unfortunately, that's where tetanus and rabies enter the mix. And so I'm really worried about these two possibilities in this patient. And so I'd be paying very, very close attention to any specific bite marks the patient has. And if we learned his dog had bit him in this lesion, and that would be very alarming. But also, I think you're paying attention to whether the patient has superimposed spasms on top of the rigidity. Superimposed spasms, which he had on his tongue, may be a clue that the patient has tetanus. So I'm really, really worried about him. And the question I think before us is, how do you navigate him to safety? And And so maybe we can air that out, Jeffrey. Like, I think we're going to get a lot of tests in this patient, but I'm curious what's crossing your mind in terms of treatment that you would institute with just this information in our pockets.
So like empiric treatment, is that what
Yeah,
you had?
yeah. What would you do
Mm,
empirically if you were taking care of him? Neither of us would be licensed to take care of him at this level of
yeah.
illness, but let's try.
Yeah. Well, I definitely think he probably needs antibiotics. I probably do broad spectrum antibiotics, making sure that we cover soft tissue infections. Um, I mean, other than that, if he seems like he, with his like dryness and things like that, could be volume down, and this is a very hyper-inflammatory state. If it's that, then I think we could give him fluids. We should definitely try the Tylenol approach that you discussed to see if that can bring down his fever. Um, I think those are the beginning things that I would
Yeah.
consider. I'm not sure from a neuromuscular perspective, would you try anything empirically or not?
Yeah, I think that's the question. That's $1 million question. I'm right there with you. Honestly, if I'm being authentic with you, I think the lack of a medication or toxin exposure and the fact that he had spasm with his tongue depressor, I think I'd probably empirically treat him with tetanus toxin. I've never done that, but it's such a lethal infection. And I also think I wouldn't be surprised if somebody else, not me, intubates him. Yeah,
Interesting.
I'm panicking about this patient. It's hard not to. We've had cases just like this, not just like this, but in this theme that turned out to be baclofen withdrawal on VMR. We've had cases like this turn out to be stiff person syndrome, paraneoplastic stiff person syndrome. Um, but the aggressiveness and the acuity, along with the lack of meds or toxins, has me worried that it's an infection. And so I think I'd probably empirically treat him for tetanus.
Yeah, that makes a lot of sense.
Yeah. We're in for a journey here, Aaron. Mike, to you.
Yeah, no, wonderful thoughts. So, on further history, the reason why this wasn't exactly brought up, this whole mass, it's because the patient's relative was the one giving history, as the patient was more uh, in slight distress in his condition. So when we saw this mass, we were like, "Whoa, we totally missed something here," because it wasn't obvious at the beginning since it was covered. But we got more history on that. So this mass actually began like 5 months prior. It started off as a soft nodular mass on the medial side of his knee. It was around 3 centimeters, and no other symptoms were noted at that time, and they didn't seek care. However, over time, the mass grew in size and became like an open wound. So the patient back then said they intermittently covered the mass with clean linens, and they did report that it was not exposed to soil, dirt, or animals as far as they know. And then 2 months prior, patient was unsure if his knee mass got infected or anything. He sought consult at an outside hospital and was given antibiotics and like hydrogen peroxide to just clean his wound, which apparently he did. But since then, the mass has been increasing in size with occasional episodes of bleeding and now associated with difficulty ambulating recently. But besides that, I don't, they were like not actively seeking care to get the mass evaluated, and I'll just stop there.
Yeah, Jeffrey, what are you thinking with this? This is very interesting.
I'm still trying to figure out how to connect
Yeah.
the mass with the rest of his syndrome. Um, I think this history basically tells us that this mass has been going on for a while. So, when I see that again, I'm going to be more worried about some type of cancer that's been some type of really aggressive cancer, either of the skin or maybe more likely something like underneath the skin, like a sarcoma or something in the soft tissue. Um, I'm not familiar with if those can produce a perineoplastic phenomenon or like an autoimmune thing. So again, like since we're getting history of this mass being intermittently covered and then they're trying to clean it, but maybe it was infected. I would say that the highest thing on my mind is going to be making sure that it's not like an infected mass. And now we're dealing with that infection causing problems in the bloodstream, like you were saying, like could this be tetanus or
Yeah.
the only other thought I had was like we don't have much other things known in this patient's past medical history. Like we don't know, is he actually immunocompromised, for example? Like
Right.
what if he has HIV and this is like something
Beautiful.
related to that. I think those are the thoughts that I have so far.
Dude, you're incredible. I think it's unbelievable how, just for all of you to know, Jeffrey sees rheumatology patients, all day, it's just incredible how much you've retained and how much the deliberate practice of your craft allows you to remain um, so thoughtful and such a big picture perspective. Because I spend a lot of time with rheumatologists, both in my personal and professional circumstances, and you're very singular in your ability and how to be such a great internist before. I think uh, maybe Aaron, I can ask you actually, just for the sake of time, because I think breakout rooms for a case like this are necessary to have people really mix their thoughts. You mind giving me a rough sense of how many alquats you have left before the reveal?
Yeah, sure. So the next aliquot will be the labs, and then there's another aliquot after that, and then I'll be giving you guys the final diagnosis.
Okay. Why don't we do this? Why don't you just give us the next aliquot in the labs, and then we'll actually do breakout rooms, and then we can reconvene after that. How does that sound?
All right, sounds good.
Awesome.
Okay, so for the lab, so let's start with the CBC. There was a hemoglobin of 6, hematocrit of 21, WBCs 28,000, neutrophils 90, lymphocytes 2, and monocytes 8. The platelets were 595, and the MCV was 94. For the chemistries, the creatinine was 4.28, the BUN was 84, the sodium was 154, the potassium was 4.1, the chloride was 118, the calcium was 7.84, the magnesium was 4.13. For the CRP, it was 78, the procal was 2.77, and the cutoff value in our lab was less than 0.5. And then I have some LFTs for the ALT. We have 25, AST 23, total protein 6.7, albumin 3.1, globulin 3.6, total bili was 0.47, and indirect bili was 0.46. For his heme parameters, the PT was 16.6, INR was 1.33, and the PTT was 28.6. TSH was done, which was 0.42, which is normal. He had an HbA1c of 5%. He also had a troponin done, which was 0.23, with the normal being less than 0.3 in this institution. He had a UA done as well, which showed +3 ketones, +1 protein, and positive nitrites, with 4 RBCs, 4 WBCs, and 190 bacteria. EKG was sinus tachycardia with nonspecific SCT wave changes. Chest X-ray was clear, and a COVID swab was done and was negative. And those are all the labs that, oh, I lied. I have an ABG as well. So the patients, sorry for all this data dump, but there's an ABG as well. The pH was 7.44, and the CO2 was 26, bicarb of 17.7, and the PO2 was 89. And I'll stop there.
Amazing. Absolutely amazing. I would encourage all of you to take either a screenshot or whatnot to take with you into the breakout rooms. Big shout out to Jillian for somehow miraculously keeping up with all this data. Jeffrey, do you think maybe you can just share with us what you've mentally uploaded as relevant data and kind of a summary, and then we can leave that for folks to mull on in the breakout rooms.
Yeah, I mean, there's a couple of things that I'm really curious about. Like,
Yeah.
this patient has or not pancytopenia, but has thrombocytopenia and anemia, and really high neutrophilic leukocytosis. So I thought that was interesting.
Mhm.
And then we have this AKI with a creatinine of 4, what we assume is an AKI, but in reality, we don't know. It could actually be CKD. and then sodium of 154. Those kind of are the things that jumped out to me. Then, of course, since I saw the creatinine, and then I went to look at the urinalysis, and there's a lot of ketones, protein, nitrite. So I'm not sure if like that is, how to interpret that. Those are the primary things that I think jumped out to me.
Beautiful. Beautiful. The only thing I want to clarify with Aaron is what I thought I might have heard them wrong. I thought the platelets were 495. Is that right, or
595.
595?
Oh, they were
Sorry,
high at
595.
595.
Super.
Okay.
Sorry, Joe.
Got
That was a
it.
lot of data.
Yeah.
Yeah. Okay, cool. Shall we nerd out with each other and go into breakout rooms for like a few minutes? Sound
Let's
good?
do it. Let's do it.
All righty. Okay, I'm opening them right now. All right. Wow. Whew. My mind is spinning, y'all. Jeffrey, where are you at? What was the conversation like?
Yeah, so we were talking about like how to put everything together. I think Ethan brought some really good points as to, could there be some type of systemic process that's been ongoing and chronic that's like leading to a lot of these abnormalities? Like, could he have like diabetes or something else predisposing to infection, like HIV, immunodeficiency, something like that,
Right.
or maybe even the CKD? And then he develops this what looks like a cancerous mass, and then we have this 2 time courses where we have this cancerous mass 5 months ago and it's growing, and we have the second time course of a more acute neuromuscular issue, which points to maybe 2 separate diagnoses, one being like this cancerous mass that's growing, and the second maybe an infection such as like tetanus that kind of brings these two together. We couldn't think of like a specific one unifying diagnosis, like some like autoimmune rheumatologic paraneoplastic thing that does everything. So that's where we are right now.
I love it. I love it. I'm right there with you. I think what I'm about to share with you all is probably the most important thing I've ever said on VMR in the last like 5 years of it. And I try to mitigate hyperbole, but I will tell you that a real life medicine is not just understanding the diseases and illnesses, but understanding people and how people respond to circumstances and behave and act. And unfortunately, that's a very murky and very difficult space to discuss in because well, you don't know the person in front of you. And if you start to make inferences on their behavior, their inferences, how they live their life, you are at risk of biases. And biases percolate our management of care all the time in very harmful ways that are described objectively in the literature. But if you don't make impressions based on holistic human behavior to guide your early impressions of somebody, you're leaving crucial clinical data on the table. And I'm about to propose to you an outlandish hypothesis that is coming out of left field, but I think it's just based on patterns of human behavior. You have this large mass growing on your leg for such a long time. I want you to all personally imagine that's happening to you. And I want you to try to imagine what your mental health and what your bandwidth to joy would be like in life. Very, very low for most people with this thing growing out of your leg that nobody's been able to help you with, right? And so that is a reality that this patient is probably experiencing that probably doesn't get emphasized here, nor does it get emphasized when you're actually taking care of a patient who's too sick to tell you that, right? Because you're getting the history from who? From a family member. But you have to take into account the reality that this patient is probably really not happy with his life. It could be, right? It would be a bias to assume that he is or isn't, but it would be foolish not to be open to either possibility and to lead with the assumption that deduces hypotheses. So I'm assuming that this person is not happy with his life. What do people do to wounds? They clean them. What do they clean them with? Hydrogen peroxide. You take an unhappy person in life and you add hydrogen peroxide, what do you get? Mouth blisters, laryngospasm, acute anemia from maybe hemorrhagic gastritis, I'm really worried he might have ingested hydrogen peroxide. And so I started to look back at the physical exam in more detail. I was like, wow, he doesn't just have laryngospasm, he has sores everywhere. Where are these sores coming from? And so I think, Jeffrey, for me, I was sitting there thinking the answer to this case has to be in some way that this thing, and I said it literally quoting myself to say that this thing is secreting something into the body. And all our hypotheses are like, is this paraneoplastic? Is this infection? Is this tetanus? But what breaks the symmetry is the fact that he's got sores on his mouth, right? And so maybe this thing isn't secreting anything. Maybe this thing is impacting the way he lives in his life, and he ingested a massive amount of hydrogen peroxide. Now that's really, really bad because it causes horrific destruction to tissue. That's why we use it. We use it to kill infections, but it can kill tissue as well. And that can cause horrific ulceration of the mouth, horrific ulceration of the GI tract, causing your hemoglobin to plummet to 6. And because you can actually have reactive oxygen species generated from this ingestion and actually air embolism generated from this infection, you can just devastate everything in the body. So it's going to be an interesting path to try to figure out, is the substance that I think we're worried about, Jeffrey, be it an infection or a toxin, is it still actively being secreted by this mass? Or are we seeing the sequelae of an ingestion? And so what would I do? I would keep proceeding with everything you just said, but I think that now history is going to be really key. Did he put anything in his mouth? And is that why he has ulcers? And is that hydrogen peroxide he was using to clean now the bottle empty? Or I'm really, really worried about that possibility because I think the prognosis would be very, very imminent, very, very concerning in this patient. So I'm right there with you. I think the key lesson as you take care of patients is, and I think, Jeffrey, your case of the acephalgic migraine is a beautiful example of how you really, really have to try to understand the person in front of you, not just their disease. So I have no additional hypotheses to share except that. And I think there are a lot of features of this case that are consistent with that hypothesis, but it's just one of many. And curious if you have any reflections on that, Jeffrey, and then we can hear from Aaron what he has next.
No, that's actually really interesting thought. I mean, I was at one point I had thought about like, could it just be like these are all completely unrelated because we know he's not a reliable historian. So like, I put in the chat because you mentioned about like the fever and hyperthermia, like maybe like these things are going on and he's like chewing betel nuts or something like completely unrelated. Maybe he feels better after doing that. And like this is completely two unrelated things. But again, I guess now that you're bringing this up, I'm wondering like, does hydrogen peroxide, which I've never actually studied before, but now I'm like thinking, is there a toxin that would cause like ketonuria, these like ABG changes, hypernatremia? And I'm wondering, is that like aspirin or something? But I again, I don't remember necessarily, but I'm right with you. Like, that's really important to see. Like, is there something else in the history that we're missing? Like, we've missed such a big part.
Agreed. Awesome. All right. Aaron, you have us bamboozled and intrigued. Mike, to you, my friend. What do you have next?
All right. No, those are some incredible thoughts, Robbie. I don't know how you come up with those, but that's such a very interesting hypothesis and very plausible as well. But yeah, I'm just going to tell you the remainder of this patient's course. So, hold on, my document disappeared. The patient, so when the patient was admitted, patient progressively became more hypertensive and tachycardic with more episodes of progressive spasticity. So any little bit of stimulation, this patient would spasm. We went back in to try to examine the pupils, and basically the patient just started spasming. So we were like, okay. And additionally, this patient did start having apneic spells and episodes of desaturation. So he ultimately was intubated. And yeah, the next day, the patient unfortunately expired secondary to respiratory arrest. The spasms just became more persistent, and yeah, I guess I'm going to stop here before if you guys have any reflections before I give you the final assessment that.
Yeah, Jeffrey, what are you thinking?
I'm not completely sure if there's
Yeah.
um,
Yeah.
something here that, we're neuromuscular disease. The only other thought that I had, which is just random, is mercury poisoning, just because I had just talked with Kirtan about it, because it causes like hypertension, dysautonomia. It causes renal dysfunction, and maybe like this UA is like Fanconi syndrome. But I mean, if this is going to be like an ingestion related, I'm very curious as to what this would be. And I'm also wondering, like, I've never seen tetanus before. Like, would tetanus still be on the table to cause these symptoms? And like, how good is the tetanus like toxin in terms of like stopping it? So yeah, that's where I'm at.
Yeah, I'm right there with you, Jeffrey. I think that I think this is either a toxidrome or a toxin. And yeah, I am curious what insight you have, Aaron. I have nothing to add to that, Jeffrey.
All right, I'm going to share my screen for what we used. So actually, we did ultimately clinically diagnose this patient with tetanus. So based on this Ablet classification, we were able to actually diagnose the patient as grade 3 severity, since his presentation was as was taught to me, was very consistent with tetanus. We initially thought that his mass was the source of infection, since that hadn't been checked. And by the way, we did plan for biopsy, but unfortunately the patient did expire, so we were unable to uh, um, find out what the mass was, but we were on the track that it was malignant. And yeah, so I guess the takeaways I got from this case was that in tetanus, like the more severe cases can just present with severe autonomic dysfunction, especially with the way the toxin works. I believe tetanospasmin is the toxin that prevents like inhibitory neurotransmitters from being able to be released. So hence all this hypertension, spasticity, increased respiratory rate, dysphagia, and tachycardia, and ultimately all this persistent spasming led to the respiratory arrest. Yeah, and then another pearl I learned was the 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 physical exam maneuver we did was called a spatula test, where you put the tongue depressor in, and that reflex spasm of the masseter is, I think, one of the tests they use to consider tetanus. But yeah.
What an unbelievable case, Aaron. I'd love to hear your reflections. I'm curious, Jeffrey, as a rheumatologist discussing a case of tetanus, what was your experience like?
Yeah, I think it was really fun. It's obviously an area that I've never, the last time I've had any case like this presented to me it's been a while. So it was really fun to get to explore, like, oh yeah, like I haven't thought in this headspace for a long time. And then to learn from you. And I don't know, I really enjoyed it. I think that what I learned from this case is that when you have a patient that doesn't really have when they give you the history, you don't really get the key information. It becomes that much harder to figure out what's going on. But the important things that you need to be thinking about are, what are the most kind of dangerous things that could be part of this presentation, and not to forget about those, and also consider like empiric treatment. So I think, a lot of the things that we were mentioning in the differential diagnosis were like key things that, if were possible, are important to test, and important as well to think about empiric treatments for. So I think that, that is at least the major things that I learned about this case. Curious to hear what your insights are.
Yeah, I mean, I think the lessons that you bring us in the academy about the fundamentals of clinical reasoning, you have so deeply entrenched in your mind that you can use them to launch such superb analyses to complex cases that have nothing to do with rheumatology. And that's why you continue to present cases of influenza complicated by strep pneumonia with a positive ANA and some Raynaud's. Yeah, I think the biggest takeaway for me is I think all of you are watching. A learner who is developing such a robust skill set at telling medical stories and having us on the edge of our seat to bring so much learning from choosing to stop at dysphagia and have the fundamentals of dysphagia built out, to all the way to the complexity of the journey, and also giving us the opportunity to sort of emphasize that medicine isn't practiced on a robot in a vacuum. You're trying to take care of a complex person whose only thing in life isn't illness. It's many other things that exist. And so generating hypotheses from that is key. And ultimately, I think you're seeing a classic presentation of tetanus. And the issue with tetanus is there's no gold standard test. So how do you ever really know your patient has tetanus? And so ultimately, I think that the world of tetanus lives in a world of hyperthermia and rigidity syndromes, and understanding what can do those rigidity syndromes will help you understand what other hypotheses there are. But every single thing on the differential diagnosis is a diffuse substance, a molecule, be it tetanospasm or any other molecule you can think of, magnesium, mercury, hydrogen peroxide. And so all those other hypotheses, I think, are things that are probably controlled by just limiting the patient's exposure to them. So the hypothesis of anything else but tetanus is not immediately actionable, because unless if you've done your due diligence and removed the patient's clothing and make sure that they've been decontaminated, there's nothing else you can do about that apart from supporting the patient. So the only actionable hypothesis in a situation like this is to presume that the toxidrome is one that the patient has ongoing exposure to, which would be tetanus in the situation. And the only other situation where something like this could happen and the insult is ongoing is when you have an autoimmune attack on your muscles and stiff person syndrome. So the landscape here is a very complicated one, but the syndrome is very, very characteristic. You have a rigidity syndrome, and there are medications and toxins that can do this, and you support the patient through them because the exposure's transient. There are ones that the exposure continues, and those are the infections that can do it, and the autoimmune diseases, which may be paraneoplastic, can do it. And so I would presume this is a case of tetanus, because that's all you can really do to help the patient, but you have to humbly acknowledge that you can't really prove that with any certainty. But given the patient's mass, the wound exposure, and presumably the lack of vaccination, it's a very, very likely diagnosis. But Aaron, what are your reflections and thoughts?
Yeah, no, I thought the same thing. I was like, oh, okay, so there's no actual test for tetanus. How are we sure that's what it really is? But I guess in clinical diagnosis, it really is just if the pattern fits there. And yeah, I agree. There's so many different diagnoses, as you guys mentioned and brought up, and even hypotheses of what could have happened to this patient. But yeah, I thought this was a very interesting case because I was like, dysphagia. I initially thought it was like a non-infectious neuro thing or maybe a GI cause, but ultimately it led to this mass on the leg we didn't even know about, and ultimately just being to the patient expiring this in like 2 days. So it was very fun for me to learn about this presentation of disease.
Yeah, I really appreciate you sharing with us, and a big shout out to Jillian for describing such a complex case, and Jeffrey I'm sorry for making you late for clinic. Oh no, we should stop. Zachariah, mic to you, my friend.
Gosh, Aaron, what a case. And I'll try and keep it quite short. So we started off with a fascinating discussion on dysphagia, and we were taught that it's actually a triggered syndrome. So most of the time, you're not able to see that somebody's actively struggling to eat. So you can start looking for clues. If you find neurological syndromes or symptoms, you might suggest that the patient has oropharyngeal dysphagia. If the patient has malnourishment and has weight loss, it might tell you that there's either something structural in the esophagus, or the patient is truly unable to eat and has malnutrition as a result. And if it's safe to do with any triggered syndrome, you should try and bring it out. And then when we went down the localization of dysphagia, we taught that it's often oropharyngeal versus esophageal as the first branch point. And then there's some clues that can help you go down that further. So often oropharyngeal dysphagia, you experience it initially as soon as the patient puts something into their mouth that they have difficulty swallowing. They often start coughing and regurgitating the food. And Rabih taught us that oftentimes oropharyngeal dysphagia is CNS related with a subacute to chronic time course and often unilateral in nature. Rarely you can have motility disorders as well. We then discussed esophageal dysphagia, which usually presents with somebody consuming something and then a few seconds later having difficulty keeping it down with a sensation that's typically retrosternal. And occasionally it can be motility related, like achalasia, pseudoachalasia, or scleroderma, but more often than not, it's structural, with esophageal masses being the most common thing we think about, but also to remember that external compression as well, from something as esoteric as a left atrial enlargement to more common things like a mediastinal mass causing that type of dysphagia. We then, well, I wanted to discuss fever and hyperthermia, but I'm actually just going to say that please go watch the VMR on the 10th of April, 2025, where I actually did teaching points on that. Eugene presented that case where there was a lot of overlap with this one. And I have to say that that was my favorite case of the year, but gosh, Aaron, you really gave Eugene a run for his money today. So yeah, so thank you. And I think lastly, we had the patient that had a fungating mass, and I realized I didn't actually fully understand that word. So I went to Google and read up on it a bit now. And whenever you see a fungating mass, it implies that there's a malignant growth that has ulcerated through the skin, eventually outgrows its blood supply and becomes necrotic, and then gets secondarily infected. So when you see a mass like this, you should really consider the possibility of an underlying malignancy. And then I think just lastly, we were taught and we know that our biases and assumptions about people actually objectively lead to patients getting worse care. And to actually become a better doctor, somebody or better healthcare provider that can provide better medical care and understand medicine better, you actually have to learn how to understand people and human nature better, as people can influence diseases in a way that textbooks simply won't be able to tell us. So thanks for an epic case, and have a lovely weekend, everyone.
Zachariah, you are the guru of teaching points. You've done them for so many years and continue to fine tune the process. I think you show us that doing the same thing over and over again can be a flat line, but I think you are showing us that exponential growth is possible. And look at the whiteboard. There's like 11 words on there, and yet the wisdom of a 4 to 5 minute spiel cannot be replaced. That was absolutely awesome. Really, really special. Thank you all for bearing with us for 16 extra minutes. And Jeffrey's apologies to your patients if they've been waiting for you. But I think we're all the better for this time. Thank you all so much.
Thanks so much. Bye.